Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. This is Cardiology Seminars brought to you by Triple N Media. On our YouTube channel, we have more than 200 cardiology lectures. We welcome you to watch them, and we also request you to subscribe to our YouTube channel. The information provided here is for education and entertainment purposes only and is not a medical advice. If you want me to research on a particular topic and produce a video, please let me know. I will be more than happy to produce that for. I have created a cardiology rounds manual, and I will tell you at the end of this presentation as how you can get a copy of this cardiology manual. The feature presentation is ACLS, Acute Coronary Syndrome algorithm. The most recent ACLS acute coronary syndrome algorithm I could find was 2017. I don't think there's much significant change since that, but nonetheless, we're going to cover some basic fundamental things which I have come across during my 40 years of experience as a cardiologist dealing with primary cardiac patients. If you understand that 95% of the patients we see are related to coronary artery disease, hypertension, chest pain. So we are constantly exposed to patients with all kinds of presentations in acute coronary syndrome category. More than 8 million people visit emergency room each year for chest pain of varying degrees caused by a multitude of factors. But when you get somebody in your car, when you're transporting somebody in the emergency room, you have no clue who is having a nervous breakdown versus who is having an acute myocardial infarction that can carry a grave prognosis if not promptly attended to. We're going to see how we can decipher as who is most critically sick and who is having an anxiety attack, and how we manage each one of these patients separately based on their clinical presentations. Since this algorithm is so complex and so minute, what I have done is I have divided them into small blocks. So we're going to go through each one of these blocks and try to understand the philosophy behind why we need to follow this particular algorithm when we are dealing with a patient with chest pain. We deal with chest pain patients ranging all the way from age 10 to 105. There must be more than 100 causes of chest pain. Coronary artery disease is one of them. So let's see how we can try to come up with a differential diagnosis. Here's the top portion of that algorithm. As I told you, 8 million people visit emergency room each year because of chest pain. When you're dealing with a chest pain patient, the first thing you need to do is monitor their ABCs: airway, breathing, circulation, and be prepared to do CPR in case it is needed. This is for the ambulance team or the EMS team. Get a 12-lead electrocardiogram. Analyze the electrocardiogram. If there is evidence of an acute myocardial infarction, then you need to contact the hospitals which serve patients with acute myocardial infarction who have facilities to deal with STEMI patients and do cardiac interventions if necessary. So there's no point in taking a patient with a STEMI to a hospital which does not provide STEMI coverage, and then you have to transport that patient from there to the next hospital, which may be 5 blocks from where you dropped off the patient. So it is prudent for the EMS team to know where each patient needs to go. As far as medications are concerned, in the ambulance, you can start these patients on aspirin, 165 to 325 milligrams. Remember the dosage because that may be a question on the test. Oxygen, sublingual nitroglycerin if they are having ongoing chest pain, and morphine if they are having an acute myocardial infarction if their blood pressure is stable. If they are having a blood pressure of 80/60, then you need to address their blood pressure first before you give morphine. Transport these patients to the place where they can be treated for a STEMI if the electrocardiogram shows this patient is having a STEMI. These are things that must be done while transporting the patient from a location. It could be home, it could be street, it could be at workplace, anywhere. Transporting them from the site to the emergency room. All these things in red must be completed. Based on the electrocardiogram, we are going to make a decision as what category does this patient belong to. Once the patient arrives in the emergency room, the patient is hooked up to a cardiac monitor, pulse oximeter, an IV is started, oxygen is given, and morphine is given if necessary. And of course, the patient will receive aspirin if the patient had not already received the aspirin. And remember the dose of aspirin, 160 to 325 milligrams. As I said, there could be a question on this one. Also provide nitroglycerin. Of course, we need an IV access and get a quick brief history and physical examination. And if the patient is going to receive fibrinolytic therapy, we need to go through the fibrinolytic checklist. I made a separate video on STEMI patients. You can watch that one where I have that list posted. We need to get cardiac enzymes, blood tests, blood count, and X-ray within 30 minutes of arrival to the emergency room, and decision must be made as to whether the patient needs to go to the cardiac catheterization lab or whether the patient needs to go to the intensive care unit for observation, or the patient can go to a regular floor on a telemetry unit. If the patient has ST segment elevation, documented on the 12-lead electrocardiogram, and if there is clear-cut evidence of an acute myocardial infarction, of course, this process begins in the ambulance, as they can electronically transfer these electrocardiograms to the receiving hospital. So the receiving hospital would be ready even before the patient is rolled into the emergency department. Once the electrocardiogram shows an ST segment elevation, then we go through this ST segment elevation algorithm, which I'm going to talk next. Then we're going to look at non-ST segment elevation group with EKG, STT changes and ongoing chest pain. Then we are going to talk about patients who have normal electrocardiogram and normal cardiac workup initially in the first 24 hours. Let's focus now on ST segment elevation or STEMI. Here is a protocol for STEMI, which is probably the simplest one compared to the other two, because you as a nurse, a ER doctor or EMT or a resident or a medical student, your job is to get this patient ready to go to the cardiac catheterization lab. Maybe you can help push the bed. That's a good thing. But it's important to look through their electronic health records if they have been in the hospital before, and get all the information, get the list of medications, the list of procedures they had, what kind of medical problems this patient has, what medications this patient is on, and what kind of allergies they have. By collecting all this information, it helps the doctors who are dealing with the STEMI to have a much better understanding of what they're getting into before they start the procedure. These patients can be started on heparin. They can also be given nitroglycerin and beta blockers where appropriate, if the blood pressure is able to tolerate that, and reperfusion therapy in case you are in a place where there is no facility for STEMI intervention. If the symptoms are less than 12 hours and the goal is to take them to the cardiac catheterization lab and perform cardiac catheterization and place a stent if that is the appropriate thing to do in a given patient. If the patient had symptoms more than 12 hours, then you may have to treat them like NSTEMI, because they have already had significant damage to their myocardium, and doing an intervention may not prevent the damage that has already occurred. Okay, that is as far as STEMI is concerned. Let's move to the second section, which is NSTEMI. NSTEMI is where we have a patient who has ongoing chest pain, whose vital signs may be unstable, the oxygen level may be up or down, they may have STT changes on the electrocardiogram, which are new compared to the previous electrocardiogram, or they may also have mild elevation of the cardiac enzymes. Let's focus on this particular box and see what we can do. Elevated troponin or high-risk patients. Who are high-risk patients? High-risk cardiac patients are those who have hypertension, diabetes, high cholesterol, smoking, kidney disease, and peripheral vascular disease, and obesity. They have multiple risk factors they fall in the category of high-risk patients, so they must be monitored more closely. So they need to go to the intensive care unit, monitor them for ongoing chest pain. If they continue to have STT changes, you get serial EKGs to see what is happening to the STT changes. If their hemodynamics are unstable, that needs to be addressed. If they are having bradycardia or if they are having hypotension, we need to address those. Any evidence of a heart failure needs to be taken into consideration. Anytime we are dealing with a patient with ischemic heart disease, we need to think about ectopic beats, ventricular ectopic beats, PVCs, short runs of VTAC, things like that. Now let's look at this next box, which is adjunctive therapy, which we already talked about: nitroglycerin, heparin, beta blockers, and some places they give clopidogrel even before doing any procedures. It all depends upon your institutional protocol. Some people would like to get all the tests done before they are placed on antiplatelet agents, because when you give antiplatelet agents, it has a permanent effect on the platelets and you can't take them out. In case the patient has to go for surgery, and if you load them with a full dose of clopidogrel, it could be increasing the bleeding risk. So that's why we need to make sure that we have very strict protocols, and each institution has different protocols. So you need to familiarize yourself. You need to familiarize yourself with your institution's protocols so that you follow the guidelines set by your institution. 2B3 inhibitors are generally not used in an acute situation on the floor. Okay, let's look at the next one, which is these patients are admitted to telemetry unit. We continue the medications. If they have any evidence of a heart failure, we may consider ACE inhibitors or ARBs. We can also start these patients on high intensity statins if they belong to particularly the high risk group. And this is the time to get an expert consultation from a cardiologist. But if you are the only doctor in town and you don't have any access to cardiologists, the best thing would be to see if you can transfer these patients to a facility with more services available, such as coronary intervention, in case the condition changes. Next, we'll look into the normal ST segment and normal troponin levels. When the patient doesn't have an ST segment elevated MI or an NSTEMI, then if they are just having chest pain with basically a normal electrocardiogram and minimal risk factors, we monitor these patients and perform non-invasive studies. If the cardiac enzymes are normal, if the EKGs are normal, if the patient can exercise, we can perform a treadmill exercise test or any number of imaging modalities like stress echocardiography or stress nuclear imaging or PET imaging. There are a number of tests available depending upon the patient's condition to exercise. On the other hand, while you are monitoring these patients, we are looking at this box. While you are monitoring these patients, if the EKG changes are seen from the previous day, if the troponin levels continue to creep up, and if the patient has continuous chest pain, then they go into the NSTEMI category and we follow the NSTEMI protocol. If they are not having any troponin elevation and if they are not having persistent pain and the EKG remains stable, next we move on to the next level. That is, we perform non-invasive studies like echocardiography, stress tests of one type or another to see if there is any evidence of ischemia. If there is any evidence of ischemia, then they go into the NSTEMI category and we follow that protocol. If the EKG is normal, enzymes are normal, if the stress test is normal and the patient is on medical treatment, we address the risk factors like hypertension, diabetes, high cholesterol, obesity, smoking, weight control, diet, lifestyle modifications, and we discharge this patient and we follow them in the clinic. So ladies and gentlemen, this is a very quick rundown of ACLS, acute coronary syndrome evaluation and management. We are talking about 8 million ER visits a year. This is something you need to get familiarized with, whether you are an internist, an OB-GYN, anesthesiologist, or an orthopedic surgeon, because if you want to pass the ACLS written test, you need to know about acute coronary syndrome. Some of the questions they're going to ask will be related to these acute coronary syndrome. If you would like to get my cardiology rotations manual, which has 175 pages of pertinent information to make your cardiology learning experience much more rich, please send me an email at drniknikam@gmail.com, and I'll be happy to send you a copy. This presentation has been brought to you by Triple N Media, and we have more than 200 lectures on our YouTube channel. And please do subscribe to our YouTube channel. And the cardiology seminars have been brought to you by Triple N Media. I am Dr. Nik Nikam, a cardiologist from Houston, Texas. I will see you in the next video.